Thank you very much, Laura, and for the invitation to come and talk. I'm going to try and avoid what will be a little bit of unavoidable overlap to Dr. Tan's excellent talk, who has slightly stolen my thunder a little bit on some of the slides. So I'm going to skip through some of the slides that you've seen before. But I think hopefully we'll have a chance to maybe dig into some of those topics that we've already started to discuss around the challenges around PrEP provision. I also, one of my many hats, the co-chair of the UK PrEP guideline writing committee, and we're just about to put out for consultation our updated guidelines, which are going to have a much greater focus on things that we've been touching on already. So the first chapter is now all about equity and access and settings for delivery, recognizing that importance of a diverse approach and recognizing that we're still, despite reasonably good but very poorly funded sexual health services in the UK, there are many people who can't or won't access PrEP if it's only being provided in a sexual health service. And also we're starting to explore some of the other things that we've discussed already. I started to discuss this morning around dosing. So our recommendations, maybe a little controversial, are going to be a 3-day leading dose for female genital tract based on some recent PK data. So do feedback to our consultation if you would like to. And we're also talking about that importance of regular STI testing, but also recognizing, I think, that the PrEP user or those who have PrEP need are a very heterogeneous group, and we quite rightly and often focus on the gay, bisexual and other men who have sex with men who have the highest rates of sexually transmitted infections. But there are other PrEP users that don't have such high rates of sexually transmitted infections. You know, people who are in different HIV relationships, you know, one partner positive but without an undetectable viral load, doesn't have the same level of STI risk. So we need a heterogeneous approach, recognizing the heterogeneous need. Anyway, that was a ramble. So I'm going to talk about oral versus injectable PrEP, building on the data that Dr. Tan has shared already. And starting with the recognition that we still have a long way to go to turn the tide on incident HIV infections globally. In 2021, there were 1.5 million new HIV infections, which is over 4,000 a day. Now, that is improvement. That's a more than 50% reduction since the peak in 1996 and a 30% reduction in the last decade. But it highlights the need, the ongoing need we have, which is expressed to a varying degree in different geographical settings to ramp up our combination approach to HIV prevention, one of which is component, obviously, is PrEP. Now, I'm going to frame some of these thoughts around 5 areas: efficacy, safety, acceptability, cost, and then a little bit of some thoughts around equity of access, and think about the 3 main available or nearly available options we have for PrEP: oral PrEP with TDF, tenofovir diazoproxil, or TAF, tenofovir alafenamide, versus cabotegravir, long-acting injectable as PrEP. So, for TDF, clearly we have the greatest data. A summary table here of all of the major randomized controlled trials demonstrating that over the last decade or more, tenofovir alone or tenofovir with emtricitabine has been studied in numerous settings geographically, in numerous risk populations: gay, bisexual men who have sex with men, trans women, heterosexual couples, different couples, with different modalities, gels, tablets, etc., and with different efficacies, as you can see there, with the greatest efficacy shown in PROUD, the UK study looking at daily PrEP, and IPAGAY, the French study looking at event-based on-demand or 211 PrEP, and other studies where there was no efficacy shown. And what we've seen also since then in open-label extension studies and in real-life experience, that when taken as prescribed, PrEP oral TDF-FDC has around a 99%, near 100% efficacy when taken as prescribed. But as Dr. Tan showed you earlier, that's all about adherence, which is all about acceptability and service models of service delivery for different individuals. So those studies that showed the greatest percentage of participants having detectable drug had the greatest efficacy. So adherence is key. So we know about HPTN 083, the large randomized double-blind non-inferiority trial with over 4,500 participants who were cisgendered men who have sex with men or transgender women who have sex with men, and good to see a study with a reasonable proportion of trans women included in it. 12.5% of participants were trans women, and as we've seen, there was a 66% greater reduction in HIV acquisition in the cabotegravir arm when compared to tenofovir FTC taken daily. And this study, as well as 084, which I'm going to show you shortly, was stopped early and demonstrated superiority of cabotegravir long-acting injection when compared to daily oral TDF-FTC in men who have sex with men and trans women. And this is a similar slide showing 084, over 3,000 participants, cisgendered women in sub-Saharan Africa, 40 instant HIV infections, and an 88% reduction or greater reduction in HIV acquisition in the cabotegravir long-acting injection arm, demonstrating its superiority to oral TDF FTC. So we've got efficacy for all of our candidates, if you like. Superior efficacy demonstrated for injectables, excellent and non-inferior efficacy when we compare TAF FTC with TDF FTC from the Discover trial. But when we move on to think about safety, we predominantly think, because TDF-FTC is our main PrEP modality currently, we think about renal and we think about bone. I think it's important to be aware of, but not overestimate the renal impact. I think those of us that see many people who are using PrEP, they're generally young, fit people with no other major comorbidities and usually not on any other medication. And what we've seen from the trials is broadly a good renal safety profile for tenofovir across all of the trials. You can certainly see mild, usually non-progressive, usually reversible, and although statistically significant, probably not clinically significant reductions in creatinine clearance in many participants. Those who are going to have greater problem and those who are going to need greater monitoring are usually easy to identify, and from the data we know that those who are older, those who have existing renal disease or other comorbidities such as diabetes or hypertension that may affect their kidneys, those on other nephrotoxic drugs, or having impaired renal function when they start PrEP, are those who we need to monitor more closely. And similarly, we see as a tenofovir effect, mild, small, statistically significant, but probably for many not clinically significant reductions in bone mineral density in those taking TDF or TDF-FTC in the trials. Again, we can identify relatively easy those who are going to be at greater risk, those with other predispositions for bone mineral density loss, those who are older, postmenopausal women, etc. So it's an acceptable and manageable and monitorable safety issue, I would suggest. And as we've seen already, there are benefits when you have access to TAF PrEP in terms of the Discover trial showing fewer drug-related renal adverse events in the group taking TAF and no discontinuations in the TAF group due to renal tubulopathy. And as we've seen already, some small improvements in bone mineral density in the TAF arm. From the cabotegravir trials, the single, as we would expect, largest safety or side effect issue was injection site reactions or injection site pain. So in 083, the men who have sex with men and trans women who have sex with men trial, 81% of participants in the cabotegravir group, that's the 81% of those who'd had at least one cabotegravir injection, and 31% in the TDF-FTC group who'd had at least one placebo injection, reported an injection site reaction. They were usually mild, they were usually moderate in severity, and they usually decreased in frequency and severity over time, and just 2.4% of participants who'd received at least one active cabotegravir injection discontinued due to an injection site related adverse event. And when looking across the other reported adverse events, there were no significant differences between the two study groups. Similar, but actually not as high rates of injection site reaction in 084. So in cis women, 38% of the cabotegravir group compared to 10% of the TDF-FTC group reported injection site reactions. Pain was the most commonly reported symptom. 4.4% of those in the cabotegravir group reported associated injection site pain, compared to just 1.1% of the TDF-FTC group. Similarly to 083, the reports of injection site pain got less frequent and less severe. They were more likely to be reported in the first injection and decreased over time. And you can see there in the cabotegravir group, injection site reactions were reported in 28.8% of participants at the first injection, but just 2% of participants by the time they got to their fourth injection. And in 083, there were no discontinuations due to injection site reactions. Just to make a comment about resistance, because this is the other side of the adherence thing. We need good adherence for efficacy, but we also need good adherence to reduce any risk of developing resistance on HIV acquisition. So excluding HIV prior to starting PrEP clearly is essential. You don't need to defer starting PrEP, but HIV testing with, I would suggest, at least a fourth generation HIV test and a repeat if somebody has had a risk within the window period to confidently exclude HIV before they start PrEP is important, and supporting adherence during their PrEP journey. And as we know, and as we've learnt from our experience of managing and supporting people living with HIV, adherence comes and goes, or adherence need comes and goes. You know, there are times when adherence is more of a struggle and there are times when adherence is easier. And we know, I think, both from our experience of treating people living with HIV, but also from some of the PrEP studies, there are certain groups who struggle with adherence more than others, particularly those who are younger, particularly trans individuals, and particularly those who use or inject drugs. And whilst it's rare and uncommon, certainly HIV resistance mutations have been identified in people who are taking or have recently taken PrEP, both in the clinical trials and in the real-world experience. This example is from the Dean Street Clinic in London, which is a retrospective case note review over 4 years, from 2015 to 2019, where they looked at all of their new HIV diagnoses and separated them into two groups: those who reported using PrEP in the 12 months up to their HIV diagnosis, and those who hadn't used PrEP in the 12 months prior to their diagnosis. 23% of those who'd had a recent PrEP exposure had an M184V mutation at diagnosis, compared to just 1% of those who reported no recent PrEP use. The group who'd had PrEP in the 12 months before their HIV diagnosis were diagnosed with lower viral loads, and also they were less likely to sequence their virus, which is one of the caveats around this trial. But it raises the issue of the concern about poor adherence with PrEP. Interestingly, the K65R, which is the other mutation we would look for in those taking TDF-FTC, is relatively uncommon, I think, both in the trials and in the real-life experience. There were no K65Rs mutations in this trial, and that's been reflected in other trials as well. And we've obviously also seen some resistance in the cabotegravir trials. So in 083, resistance was detected in one of the 4 cases who had HIV at baseline, so a transmitted resistance, not resistance as a result of their injectable PrEP. and incident resistance was detected in 4 of the 9 incident infections during the study who had had a resistance test. And the commonest mutations here were the M184V, the M184I, or a combination of those, and they did have a couple of K65Rs as well. So just reinforcing the importance of, I think, whatever PrEP modality we're using, excluding HIV at baseline and maximally supporting adherence is really key. In terms of acceptability of different options, we've already seen Dr. Tan's Toronto data, and that's reflected in other surveys and studies where injectable PrEP is at least equal to our current oral options, or in some settings more preferable to current oral options. So the first 2 examples I've got here are both studies that were done in different populations prior to the 083 and 084 results being released, so when injectable PrEP was more of a hypothetical rather than a reality. So in this first study on the left of gay, bisexual and other men who have sex with men in the States, 46% reported preferring the option of an injectable, with 14% preferring oral PrEP. About a fifth didn't really mind as long as they had confidence that it was going to work. 10% had no preference, and I think it was about 8% that wouldn't want to take PrEP at all. And those differences were pretty similar when they analysed it by race, ethnicity, educational status, income, and where they lived. And as is seen in other studies, key priorities, if you like, for potential PrEP users are concerns about long-term health and side effects. In a slightly smaller study in South Africa of people attending rural clinics for a range of things. So some of them were actually coming in for PrEP consideration or PrEP prescriptions. Some were coming in, the majority actually were coming in for family planning reasons, and some were coming in for HIV testing or STI screening. 109 individuals, the majority of whom were women, mostly young, median age of 28. 75% of those respondents expressed a preference for injectables over daily oral PrEP. And of the women who were already using or had previously used PrEP, the majority stated a preference for injectable over oral PrEP. And there's a more recent study that's a preprint actually at the moment, online at the end of last year, end of 2022, in Holland, a Dutch survey of just over 300 men who have sex with men, asking about intentions around PrEP and preferences around PrEP. These were a group with relatively high PrEP uptake. About 60% of them were on PrEP already, and about 10% of them were defined as poorly adherent to their PrEP. 83% of those showed very high interest in injectables, and 63% showed high or very high intention to use PrEP. And when they looked at the relatively small group of people who were already poorly adherent to their oral PrEP, the interest in injectable PrEP was higher in that group, although the intention to use it wasn't. And the authors suggest here that, particularly for those who are currently struggling with adherence to oral PrEP, injectable PrEP is a potentially good option. Now, in any setting, whatever your healthcare model is, but particularly in lower middle income countries, and particularly in countries like the UK where we have publicly funded healthcare, we can't have a conversation about any of these prevention strategies without talking cost. Now, clearly, pros and cons. Generic TDF-FTC wins on this one because it is very cheap. Descovy, somewhere in between, and cabotegravir is much more expensive. Using UK figures as an example, it costs about £7,000 UK pounds a year, and that compares to about £168 a year for generic TDF-FTC. And generic TDF-FTC can be as little as $50 in lower middle income countries. And now clearly there are two components to what impacts on cost effectiveness of these interventions. One of them is targeting the groups who are going to benefit the greatest, those who've got greatest risk, and the second one is how much the intervention costs. A South African cost-effectiveness analysis suggested that the cabotegravir injectable in their setting would need to cost somewhere between $60 and $120 a year to make it as cost-effective as TDF FTC. Now, there is a voluntary license from ViiV which allows generic provision in 90 countries. It's not everywhere, and that in itself is a little controversial. But I think it leaves us at the point, clearly, that I don't think there is a setting where branded cabotegravir is cost-effective, and really to make injectables a feasible alternative to generic TDF FTC, we need to see significant reductions in price. So just to edge towards a bit of a summary, you can discuss whether or not you agree with this, but if we think about efficacy, clearly if we pick the right choice for the right person, they're all efficacious. I mean, I've given cabotegravir 3 ticks because we do have superior data from the 083 and the 084 study. They all have manageable and predictable side effects or safety issues, and I don't think there should ever be a barrier for us or for individuals taking any type of PrEP. Perhaps TAF FTC gets an extra tick because it's easier on the kidneys and the bones. Acceptability is an individual choice issue, so what's acceptable to one person it may not be acceptable to another, and it's our job to try and ensure that we have as much choice as possible. We have some survey questionnaire data that suggests that some groups would prefer injectables to oral PrEP. TDF FTC wins on cost, obviously, and cabotegravir loses on that one. Equity of access is more than just the mode of PrEP that we use. It's about how we're engaging with communities. It's about how much we're raising awareness, raising knowledge about PrEP. It's how we're tackling stigma. It's how we're looking at different settings for provision. Perhaps, certainly, I think particularly for women at risk of HIV, cabotegravir injections or injectables, or certainly other non-oral modalities maybe have a bit of an edge. So clearly, to continue to make strides on the HIV epidemic, we need to be ramping up PrEP as a key component of our combination approach to HIV prevention. There are multiple barriers to equitable access. Awareness, particularly in marginalized and disadvantaged groups, individual or personal risk assessments where people don't perceive themselves necessarily to be at risk and therefore don't think PrEP is for them, stigma, cost, and how we deliver our services. But PrEP certainly is cost effective when targeted at those most at risk of HIV acquisition, but I don't think cost effectiveness should be our only measure when we're thinking about our range of PrEP products. And as we've heard already, more choice has the option to increase uptake and get better access for those who are not accessing PrEP already. Just some final data from the UK where we are seeing, as I'm sure other settings are, really significant contributions to PrEP to our HIV incidence rates. This top line here is diagnosis of HIV in gay, bisexual and other men who have sex with men, which has dropped by over 2/3, over 66% in the year since about 2014. Now, PrEP is not the only thing that's contributing to that, but it is making a significant contribution. And I'll finish on that slide because I've been reflecting when I do talks about this, about how certainly in the UK, PrEP provision has been more than just a clinical or academic approach. It's been activism as much as anything else. And certainly in the UK, since 2014, when the preliminary PROUD study results came out, we've had a real battle to get PrEP into the hands of people who need it, including having to take NHS England, who now actually employ both Laura and I, to court to kind of force them to prescribe it. Anyway, we've moved from a point where we had an implementation trial running up to 2017 with 26,000 people to nearly 70,000 people on PrEP now, but it's not nearly enough. And so I would encourage all of us to use our power and influence and work with our community partners to agitate for PrEP for all. Thank you.